as well as neurotropic of intracerebral hemorrhage and stroke. Tries to pronounce all that. Dr. Wensel specializes in spine surgery, functional neurosurgery, including deep brain stimulation for Parkinson's, stereostatic surgery, and robot-assisted surgery, and he has an active general neurosurgery practice. He's also the surgeon who performed my deep brain stimulation surgery last year, twice. But for me, it's been a life-saving, life-changing surgery, and it's made an incredible difference in my quality of life. Dr. Karlo Lizarraga, who's in the red sweater over there, is a neurologist and clinical neurophysiologist with additional training in mood disorders, motor physiology, and neuromodulation. He's also a professor of, I'm going to pronounce this university wrong, so I'm saying professor at the University of Peru. At the U of R, Dr. Lizarraga is the director of the Motor Physiology and Neuromodulation Program, in addition to being the director and founder of the Neurology Peru Rochester Exchange Program, NeuroPro. His passion is to optimize the understanding, diagnosis, and treatment of mood disorders with the use of neurophysiological techniques and to develop international collaboration that promotes global equity in neurological education and patient care. Also, Karlo Lizarraga, who's a nurse in the Deep Brain Stimulation program is here, and she's generally in the OR with the surgeons, kind of holding your hand, explaining what's happening, why it's happening, and what's going to happen, and is generally a lifesaver. And so without further ado, I'd like to, I'm not sure, I think Dr. Lizarraga, you go first. Welcome.
Thank you. I don't want to be recorded, so I go in the back. Well, nice to see you, everybody. I know some of you. Thank you for coming. So today Dr. Wensel and I are going to discuss deep brain stimulation. I want to be very clear from the get-go. Deep brain stimulation is what levodopa was in the 60s, 70s. Which means that in terms of treatment for Parkinson's disease, DBS is a big deal. It changes the way your body moves, which is the same thing that levodopa did when it was discovered in the 70s. I don't know if you have watched some of those movies. One is called Awakenings, about levodopa. So we are actually going through a similar revolution in care thanks to DBS. So the key is to combine levodopa and all the benefits with DBS and try to blend them and provide the most improvement in the quality of life. Okay, so that is what we try to do with our patients with DBS. Now, the main question you probably have first is who is a good candidate for DBS? To me, I'm biased because I've been doing DBS for several years now, and I've been doing research on DBS, and to me, everybody is a good candidate for DBS. And actually, that is one of the current pushes in the DBS field from the research perspective. We're trying to figure out how early can we do DBS. Because in the past, when DBS just started, as with any other procedures, when we start learning about something new, we are very careful and cautious. So at the beginning, the procedure was offered only when the complications of levodopa were very clear. The fluctuations, the dyskinesia, the wearing off, and then DBS was offered, and it made a big difference in quality of life. But over time, we are learning, and maybe we don't have to wait until those complications are so bad. Because what can happen is usually when those complications are at a bad state, it means that Parkinson's has progressed in other areas also, including cognition, psychiatric dysfunction, other symptoms. And then when we do DBS at that stage, sometimes DBS is not as good because it can make some symptoms a little worse, right? So because of that, we are trying to understand if we should be doing DBS earlier on in the disease course. And number one. Number two, there is some evidence that, at least in animal models, that DBS may actually alter the course of Parkinson's. And you probably have seen some news or have read some articles about this. Again, the evidence is not clear, but it's at least a question that is worth exploring. Any questions so far? Okay. So again, yes.
How early? How early is your opinion?
How early?
Like,
That's
as
we
you're
don't-
diagnosed, or?
Yes, so that's what we don't know, but the studies, I think the main source of possible mistakes would be if we do DBS in a patient who does not really have Parkinson's disease. And so if you look at the diagnostic criteria for Parkinson's disease, it used to be that we had to wait at least 5 years of following the patient carefully, doing some workup to make sure that it is actually Parkinson's disease, and then the criteria for DBS was, the first one was, if the patient has Parkinson's disease, wait at least 5 years. Now we are learning more and more, so that has been shortened to 4 years. So right now we have to wait at least 4 years after symptom onset to start thinking about DBS. Okay, but that's not because we don't think DBS could work earlier on. It's because we have to make sure the patient actually has Parkinson's disease and not the Parkinsonisms or other conditions that can mimic Parkinson's disease.
So what direction does it go in once you do the stimulation? Is it a good way or a bad way?
What direction for what?
When you suddenly do the brain stimulation, it could send Parkinson's in another direction.
Okay, so if it's a patient who does not have Parkinson's disease, it has one of the atypical Parkinsonisms, DBS would not make a difference in the final outcome because those conditions have 5 to 10 years of expected or life expectancy. So it's mainly like, are we really helping? And the answer is probably not. But if it is truly Parkinson's disease, then the life expectancy doesn't really change. Like people who have Parkinson's disease have the same life expectancy as healthy people, right? That doesn't change. But what we do with DBS is we significantly improve the quality of life. Make sense? Yeah. Okay. So what we do in the first 4 or 5 years after we think somebody has Parkinson's disease, we put them on a medication called levodopa because that is the best. It's the most potent, it's the best treatment for motor problems, tremor, slowness, stiffness. Okay, so those 4 or 5 years of patients being on levodopa are helpful to us to make the diagnosis and also helpful to the patients to see if they respond to the levodopa or not. If in those first 4 to 5 years, levodopa starts causing problems, then DBS can be offered right then. What problems am I talking about? Dyskinesia, which is when the levodopa is working, it works too much, and the patient starts moving. Like having involuntary movements, too fast. So like levodopa makes you move better, but sometimes it overshoots and makes you move more than what you want to. So that's called dyskinesia. Those usually are wiggly, twisty movements of the hands or feet or the head.
Right.
Yeah.
Kind
Now-
of like Michael J. Fox
Yes,
is currently.
exactly.
Yeah.
Now, what also happens after being on levodopa for several years is that when it stops working, it also goes too low. That's called wearing off or off periods. That combination of dyskinesia or working too much and not working enough, that is called fluctuation. Motor fluctuations, and that is the main indication for DBS. So right now, if somebody has at least 4 years of disease, And motor fluctuations, that already makes them a good candidate for DBS. Okay? To give you a little more data, if you like numbers, 50% of patients who have been taking levodopa for at least 5 years are expected to develop motor fluctuations. So half. And that number goes higher the longer the levodopa is used. So in 10 years, that 50% will be like 70% or even more. And DBS will be helpful. Any questions so far?
So if you,
So,
So if someone has had the disease for 4 years, but it's only been on, say they've only been on levodopa for 1 year, and it doesn't stop their tremors when they take it, they're kind of candidate also?
yes.
and when they give you an extra medicine on top of the levodopa?
Yeah.
Could that increase the fact that you're going to shorten that period where you're going to get those tremors more?
That is a great question. And that's the reason why in the past, many neurologists delayed the start of levodopa. But now there's been very strong data and good studies that have shown that there's no difference. So that's why we start levodopa right away. Because the time between starting levodopa and developing motor complications will be the same, regardless of other medications that are added.
And it's like an extra levodopa.
It could be extra levodopa, it could be other classes of medications like pramipexole, selegiline, entacapone. There are many other medications, but those other medications are used to help levodopa. They don't replace levodopa. They can make levodopa act a little longer or smooth it, the action, but they don't replace levodopa, okay? Yes.
I was just wondering, getting back to the time, to need to wait to make sure that the person has Parkinson's. The discoveries that were made last year regarding the biomarkers and that, will that trickle down and help confirm a diagnosis?
I think so, yes. Yes, also in patients who have a family history and a known genetic cause of Parkinson's disease, we tend to do DBS earlier on or faster because we know they have the same genetic problem and we don't have to wait the 4 or 5 years.
Is the DAT test confirmatory?
The DAT scan,
Yeah.
the DAT scan is not confirmatory, but it can help when there's doubts that maybe it's something else.
And for the delta of time between starting levodopa and the motor fluctuations, does taking like the minimum effective dose elongate that time?
That's an awesome question too, and the answer is no.
Okay.
So there is the brain has a clock, sounds like. The brain has a clock of from the start of Parkinson's disease until the disease progresses enough that motor complications will be present. That time doesn't change with the timing of levodopa being started or the dose being higher or lower, or the medications being added to the mix.
Does exercise elongate that?
Exercise can, yes,
Yeah,
actually, but the data is not as strong because it's really hard to do a clinical trial with exercise. But exercise has been shown to even possibly delay the progression and all the other complications, yes.
Is there a difference between Parkinsonian syndrome and Parkinson's disease?
Yes,
What is it?
great question. So, Parkinsonian syndrome or Parkinsonism is an umbrella term that includes many conditions that present with a similar group of problems. Tremor, slowness, stiffness. The 90% of the time, it will be Parkinson's disease. The other 10% can be some medications, like medications used to treat psychosis, like schizophrenia and similar. A brain tumor, a stroke in a certain part of the brain. The atypical Parkinsonisms, like multiple systems atrophy, and other similar problems. So that's what we have to do in those 4 years. As neurologists, we have to slowly rule out that it's not something else and then be sure that it's 90% of, it's the 90% that it will be Parkinson's disease.
The how should I? If you've been examined by a neurologist and your cervical spine is really in bad shape.
Yeah.
They have to do decompression on four discs. Could that problem actually be like Parkinson's?
Yes, it can. So that's a great point. So when you have any condition that is affecting the motor system or movement, then patients that can look like they are slow. So slowness of gait, for example, slowness of movement can be caused by a spine problem, especially in the neck. But the good exams should be able to tell if that slowness is from a Parkinsonian syndrome or from a spine compression, because we will see other problems. Now, there are some people that are gonna have both. That's the hard part. Some people have Parkinson's disease and develop cervical spine problems. And then they all of a sudden are more slow, they have more gait difficulties, and sometimes we have a hard time distinguishing, is the Parkinson's all of a sudden getting worse for some reason? But we need to also look for spine problems or other conditions. Make sense? Yes.
What if someone develops hydrocephalus?
Hydrocephalus?
Yes.
Yes.
Now, do you treat the DBS, you treat the hydrocephalus?
Yes, so hydrocephalus can cause also Parkinsonian syndrome. But the treatment would not, so DBS would not be used for that condition. So DBS is only for Parkinson's disease. Approved at least. There's some research in other conditions, but for care, we only use it in Parkinson's disease, okay? So the one thing that we do in our program and in any other DBS program in the world actually, because it's so important to make sure that it is Parkinson's disease, we do what we call a levodopa challenge. So we ask our patients that are potentially good candidates to come to our clinic without taking their levodopa or any of those medications since the night before. So when they come to our clinic, we do an exam and we examine them in the off state, so they are off the medication. Then after doing that first exam, we give them the levodopa in our clinic and we wait until that medication starts working, which is usually between around 40 minutes, right? Depending on each patient. Then we examine them again and we need to document that there is an improvement in the motor exam between the off state and the on state. Because that is one of the main diagnostic criteria for Parkinson's disease. And number two, that is unfortunately the only way we have right now to predict or approximate or estimate how helpful is DBS going to be. This is a very important point, so I want to make sure we are all understanding. When I say unfortunately, it's because levodopa is mainly a motor medication, right? So it's helpful for slowness, stiffness, tremor in some cases, but it doesn't necessarily improve other areas that can be important for patients, like cognition, constipation, like having bowel movements, other just normal areas of daily living. So the estimate that I'm talking about is what DBS will do for the motor part of the quality of life. If a patient has a very good response to levodopa that we are able to document and score, that means that DBS has a high likelihood that it will provide great motor benefits. Okay? And the reason is because the way DBS works, it's by ameliorating the fluctuations that levodopa causes. So if levodopa is really helpful for patients, then DBS will be helpful because DBS is just making sure that levodopa is not excessively working or working too little. We're keeping the levodopa at a smoother state. Yes?
Is that definition of Parkinson's disease, the 4-year clock starts at the time you've got an off-on cycle difference?
The time starts with disease onset. So if the onset it was tremor of the left hand, for example, that's when the 4-year clock starts.
So it's not necessarily when you were diagnosed,
Exactly.
it's when you started
With the
seeing
motor
differences in your movement.
Exactly. The first symptom consistent with Parkinson's disease, that is when the time starts. Because there is diagnostic delay, right? So some patients have tremor or gait slowness and it takes 1 or 2 years to actually be diagnosed with Parkinson's disease.
Right.
Then it would be unfair to wait 4 years after the diagnosis. That would actually be 6 years. Right? So we do it from the time of symptom onset. Yes.
So in people who have tremor predominant Parkinson's disease, and the tremor is refractory to levodopa, does that mean they're not a candidate for DBS? It's likely to work.
Yeah, so the tremor is a little more tricky because the diagnosis of Parkinson's disease should be independent of tremor, right? So we are using the 4-year time frame for diagnosis of Parkinson's disease, not for tremor being refractory to levodopa. So if you have tremor that has been going on, let's say 2 years, and it doesn't respond to levodopa, you may not be a good candidate, not because of the tremor, but because we want to wait until you actually have Parkinson's disease documented and meeting the diagnostic criteria. The other part that is tricky with tremor is that in some patients, we need a lot more levodopa for the tremor to respond to the medication. Yes. Time? 5 minutes. Okay, well, I'm glad we started with the questions because.
So if I heard you right,
Yeah.
the deep brain stimulation will help with the movement, but not cognition. Is that correct?
Yes.
Okay.
I'm gonna expand on that very good question.
To ask a further question about spinal cervical spine, and can that also contribute to a tremor?
Very good question. No, no. So
Okay.
spine compression should not cause tremor.
And how about a cavernous hemangioma of the pons?
Yes, that can cause tremor.
What is that?
I have
It's a lesion of the pons. Yeah, it can cause tremor.
it can.
So what's your name? Sorry.
Miriam.
Marion. Marion asked a very good question about DBS affecting non-motor parts. Okay, but this is another very important point that I want to touch. So just to reiterate, DBS will be effective for the fluctuation. Okay, so if a patient has motor fluctuations going up and down, DBS is the best treatment for the fluctuations to make them less pronounced. That's motor fluctuations. From the non-motor perspective, there is some data that has shown that DBS can be good for sleep and some gastrointestinal problems. Particularly DBS of one of the targets called the subthalamic nucleus. That is consistently seen, and many of my patients actually come after being programmed saying, oh, I'm all of a sudden sleeping so much better. But we don't offer that as part of the process because it's just part of the benefit. Now, in the same way, there are some symptoms that can be impaired by DBS. The most concerning one is cognition because it can be unexpected and it can be very disabling. So because of that, as part of our selection process, we also do a neuropsychological testing to have a better idea of what is the baseline cognitive function of this patient. And if there is a deterioration after DBS or after their surgery, if that could result in have a negative impact, okay? We know, we don't understand exactly why, but we know that DBS can reduce certain cognitive functions, like in particular one that is called verbal fluency. So the ability to come up with words can be reduced after DBS of that same target, the subthalamic nucleus. But verbal fluency, like that reduction, may not be bad enough to cause any problems in many of our patients. But because of that, we want to make sure we do neuropsychological testing in everybody. And if we find that they are close to being on an abnormal range, maybe they are not the right candidate because DBS will tip them off and cause problems. Okay, so that's one, cognition. The other one is balance and gait, and particularly freezing of gait can get worse after DBS. Also of that same target, the subthalamic nucleus. And then speech. Yeah, so this surgery has like clear benefits for the motor fluctuations, and then the risks. There are some risks that we all take. I think sorry that I'm gonna say it this way, but what is good about these risks is that they are in theory reversible, because we can always turn off DBS or minimize the settings or even remove the whole system if it's causing problems. Okay? We haven't had to remove the system in any of our patients because of the side effects, but we have had several patients that needed advanced programming to reduce the side effects. And I'm gonna finish kind of touching on what's coming, because we have now new technology that has some promising ability to tailor the stimulation to the symptoms that we want to improve without necessarily causing more side effects. So you're going to read, I'm sure, if you haven't read, about something called adaptive DBS. So what's happening is that now with the leads that are in the brain, we are able to measure brain waves. And we have been able to identify a particular pattern of the brain waves called beta that is clearly associated with the motor problems of Parkinson's disease. So when there is more beta, patients have worse Parkinson's symptoms. And when there is less beta, the symptoms are better. When you use levodopa and the symptoms improve, the beta goes down. Same with DBS. If we target that beta, that will lead to improvement in symptoms. So because we have that good marker of motor symptoms, we can use that marker to stimulate a certain area of the brain where that marker is at the highest, right, or the worst. But what it's, to me at least, given my research and my area of interest, what's most important is that we will avoid stimulating the brain all the time, right? Because that's how DBS works now. We just turn it on at a certain setting and it has to be on all the time. Which it may be good because you're trying to ameliorate the fluctuations that are happening throughout the day, but you're also stimulating other signs or other waves that are not necessarily the bad ones. Right? So ideally, we only want to stimulate the beta, get rid of the beta so that the symptoms are better. But all the other waves that are there, brain waves, that have normal functions, are also being stimulated and altered by DBS. Does that make a little bit of sense, or it's kind of an advanced? Yeah, so we're trying now to use that ability to measure brain waves to change the way we do stimulation, and that's going to be our next big step in the DBS field. In fact, we have been contacted to be a site for this new research. Okay, so because adaptive DBS is on the way to being approved. But now the company, and of course we have to now do research on real world data. So we have to use this called the phase 4. So after you have a treatment approved and you market it, we have to still monitor and capture data. So we're probably going to be a site for this new phase of this adaptive DBS. Okay, yes?
So it's really a replacement for having to take something like entacapone, right? you don't take the drug anymore, this levels it out.
Yes.
I mean, on a simplistic level.
Yes. But, okay, so you bring that up a great point, so it's like a honeymoon, right? So levodopa, when you start it, there's a honeymoon period, around 5 years where it works like magic. And then after those 5 years, as I said, around 50% of patients start having the fluctuations. DBS has also a honeymoon period that is also around 5 years, where we will be able to, if the lead is in the right place, and we stimulate with the right settings, we will be able not only to get rid of the other medications, but we can also reduce the dose of levodopa. Now that is going to last, again, that honeymoon period, around 5 years, and then the disease will catch up. And then we have to increase the medication again or start other medications, and but I think what matters to us is trying to improve your quality of life as much as we can, for as long as we can.
Does the levodopa start working again if you have a vacation from it?
Yes, totally.
So if you get the deep brain stimulation, do you still take carbidopa, levodopa?
Yes.
In addition to that?
Yes. There are some patients in which you can stop levodopa, but it's rare. It's rare, and I don't recommend that, but some patients don't need to take it.
Right.
How does it differ from now, there's a pump, like an insulin pump type of thing that just approved to get a steady state. I mean, obviously, one's brain surgery and one's not.
Yeah.
Isn't that achieving the same thing?
It is. Yes, it is, and I think we are just going to learn more about this pump. I would say right now, if there is a patient who has motor fluctuations with the oral levodopa and becomes a candidate for DBS, I would still go through the process. And if there are contraindications for DBS, like having freezing of gait, for example, or cognitive problems, then that would probably be a better candidate for the pump. Actually, after the second honeymoon, the DBS honeymoon, there are patients who benefit from having the pump added. So when DBS is not enough to control the levodopa fluctuations, then the pump could be used in addition to DBS.
I gather that the adaptive DBS is a different implant battery. So one can have the conventional DBS surgery and then later move to the adaptive model?
Yeah, that's a great question. My understanding from what the company has shared is that the Percept batteries may be able to be upgraded to the new technology that will allow us to do the adaptive DBS. Because we can already measure brain waves using Percept or the battery model. So I mean, this is not official, but I'm hoping that we will not have to replace it with a new battery, but we could probably upgrade the one that's already in place. Yeah.
How invasive is the surgery and what's the recovery time?
Okay, so this is a great question that it's going to help me transition to Dr. Wensel. He's going to talk about the surgical aspects, and I think what's also another important message that I want to make sure I don't forget to deliver. The DBS has the outcome of DBS is first the right candidate. So it has to be a patient with Parkinson's disease, motor fluctuations, but the expectations of the candidate have to be aligned with what DBS can actually do. So that way it takes some time for us to move on with this process because we need to make sure that the patients understand what DBS is actually going to do. Okay, so that's number one, aligning candidacy with expectations. And then number two is the lead location, which is what Dr. Wensel is going to discuss with you. If we are able to put the lead in the place where we want it to be, and it's on the right patient who has a clear expectations, those are the best outcomes we have, okay? Awesome. Yes?
I had a quick question. Did they mention about the adverse effects on cognition?
Yeah.
And speech? Of the patients we've seen, approximately what proportion have those adverse effects? And how strong are they?
Great question. So we see that in about 20% of patients who have implanted the STN, the subthalamic nucleus. They can have this unexpected side effects in terms of axial problems with speech, freezing gait. And then the cognitive one, we don't really see that because we do the neuropsychological testing to make sure that's not gonna happen. But the cognitive side effects can happen later on, but it's usually not the stimulation, it's usually the disease progression catching up.
Just another quick question. Are there any pharmaceuticals for the cognitive deficits that you see?
Yeah, there are many drugs that can be used for cognitive problems, but they are not that effective, unfortunately. Mainly what they do is they improve alertness.
Okay.
So it helps patients be more awake and focused on what they're trying to do. But cognitively speaking, there's really not right now anything to improve that. That being said, if you have, it's like exercise, right? So exercise for the body has been shown to have good benefits in motor function, balance. I think that also exercising the mind and being cognitively active could also have a positive impact on that.
Does DBS affect the mood disorder part of Parkinson's at all, depression and anxiety?
So that also depends on the target. So with STN, there is a chance that stimulation could impair or alter mood. So we are also careful with those patients, and we luckily have a psychiatrist with our team now, and we can have a special evaluation if that is a concern. Now, and I'm gonna finish with this part. So another advance that we are already using in our practice is called directional stimulation. So in the past, we could only send the electrical impulses in a broad way, so like a sphere, and the electricity would spread around the contact. Now, we have directional stimulation, which means the contact is split into 3 segments in like a cylinder. And so we can tell the stimulation to be sent only in a certain direction. So what we are seeing with that is we're seeing less side effects because we can avoid the electrical impulses to go to bad areas that could alter mood or cognition or speech or gait. That's part of the research we are doing actually to try to decrease the side effects. Okay? Thank you.
Thank you.
All right. Thank you all for coming out. My name is Andy Wensel. I'm the neurosurgeon that does the deep brain stimulation in Rochester. I am from Rochester. I grew up in Penfield. I went away for my training for undergrad in medical school and then came back for residency and stayed on here in 2009. Thank you, Dr. Lizarraga, for that. You did a great introduction to a couple of the points I was going to touch on as well. So it's good to have that as a introduction as well. There's several familiar faces here today. So there's at least 5 people who have deep brain stimulation sitting amongst you. So they may identify themselves to you, or you can always ask them individually later what their specific experiences were. We always do this as a standard beginning to any talk. I don't have any financial disclosures. I'm not paid by any of the companies to speak about any of this. My conflict of interest is that I'm a deep brain stimulation surgeon. So I do it, so I believe in it, just like Dr. Lizarraga said. So that's a bias that you'll hear in my speaking about this. I do use some Medtronic slides and data during the presentation because they describe a lot of the advantages in the technology in some ways that I can't, because I don't have a medical illustrator to be able to do that with. So I do use some of their slides. To give you a little bit of a overview, I want to play this video of one of our patients from a few years ago named Cindy. Kind of talks about her whole experience. She has Parkinson's, and it kind of gives her whole experience in 7 minutes. And that's a good broad exposure to the surgery to start, and then we'll kind of go a little further. So the sound's just going to come out of this projector, so if you can't hear, my apologies. I'll turn everything up as high as I can go. And hopefully it'll play.
I feel like $1 million. I have had DBS surgery, and since then, I haven't had any problems I had before.
DBS, or Deep Brain Stimulation, is an implanted surgical device that allows us to control the motor symptoms of Parkinson's disease, essential tremor, and of dystonia.
DBS therapy uses a medical device, much like a cardiac pacemaker, and thin, soft, flexible wires, called leads, completely inside the body. While the device is implanted beneath the skin in the chest, the leads are implanted within the brain. Electrical stimulation is then sent directly to targeted areas within the brain. Stimulation of these areas enables the brain circuits that control movement to function better. This results in a reduction of some symptoms in many patients.
Cindy was a good candidate for deep brain stimulation because she'd had Parkinson's disease for years. Also, she had started to see early wearing off the medications and inconsistent response to the medications.
And you can see it in my hand right now. My hand's not working yet. This happens once in a while. The medication just decides not to work, and my frozen time lasts longer than my on time. It's how it's all cramped up. Like the doctor will have me do this. I can do it with this hand fine, but this hand, it doesn't work. That's a sign that medicine's in between kicking on and off. And then when I finally kick in, they start another side effect, which is a lot of movement. My foot will go like this and it won't stop.
The surgery is considered when medications don't seem to be working as well. There's your lifeline. It can be early in the process of the disease, it can be later.
I've fallen down the stairs. I broke some ribs. It's a tough battle, but I'm trying to be strong with it. A bad day would be like it was this morning. I took my medication and it took almost 2.5 to 3 hours to kick in for the first round. Today is a day that I really wouldn't want to go outside and drive or do anything.
The initial surgery where both electrodes are placed takes a couple hours to do, is done on one day and you stay overnight, go home the next day. The surgery is done under local anesthesia. There's very little discomfort.
So we're gonna drill 2 small holes about the size of a dime. Through that, we'll pass this electrode, okay, so that will go down. We use this very thin metal plate and it covers it up, it's titanium.
That stays in there.
That stays in there, yep, as do those wires.
Right.
And then for life, the therapy will continue for as long as you need it. There's no pain receptors to the brain itself, so it's not painful. It just is weird sensations.
I'm gonna be scared, but I'm gonna do it. No matter what, I'm gonna do it.
There's a second surgery about 2 weeks later, during which we implant the pacemaker. That's an outpatient surgery. People go home the same day.
And that will go in where a pacemaker typically goes, just up underneath the clavicle.
It takes about 2 weeks of healing after the last surgery before we can start turning on the electricity and tuning to control symptoms. This is due to the natural healing process and how it affects electrical stimulation in the body itself. All right, now we're going to the barber shop. How you feeling?
All right.
During surgery, we need to be able to interact. We'll passively move your arms and legs to confirm we're in the correct place. And we will actually have you move your joints.
Can you tap these toes up and down? Cool.
I don't think I'll ever make it as a hairdresser. Good job.
Thank you.
Over there.
Yeah,
Okay.
thank you. Yep.
See you back in the recovery room.
All right.
Can you let go of my arm and let's see how much you can do? There you go. You wanna turn? Yep. Okay, here we go. I tell myself big steps. Big steps? Big step. And when your meds have been working in the past week, your feet are free to do what they wanna do? Yes, when they're working. When they're working. So the goal is gonna be to get the DBS to liberate your feet here. Okay. You ready? Yeah. Okay, here we go. This is just gonna gradually increase the amount of currents coming through the wire. Just let me know as soon as you start to feel anything good or bad, okay? Tightness in my neck, in my leg. In your leg, okay. Open and close here. Let me see your wrist. That is definitely looser. Okay, I'm gonna leave it there. We start off with the voltage a little bit lower than kind of the maximum that your brain is happy with, just because we're gonna want room to gradually sneak up to that voltage rather than starting from there from the get-go. So over the next several weeks, we'll be gradually raising the intensity of that stimulation to help improve the symptoms when your medicines have worn off. Here's the key now. Let's see how your walking goes.
Yeah, that's cool. That's really cool. Who wants to dance?
Let's walk.
Okay.
Piece of cake.
Piece of cake. Walk in here. Yeah, we need your help now.
Okay, come on back. You're not getting stuck at all.
Nope.
That's great. Any other questions about your new bionic brain?
No, let's make sure it doesn't fail me.
Very good.
For Parkinson's disease, deep brain stimulation usually offers sustained improvement of tremor. Second would be improvement of rigidity or stiffness. There's usually a reduction in medication, and that can be up to half of the medication that's usually taken or more. It's also tunable. So as Parkinson's gets worse with age, we can actually increase the voltage. We can change the number of pulses that are provided per second. That allows us to sustain the effect of deep brain stimulation for many years. Now, a couple months out from surgery, Cindy is experiencing an improvement in her overall symptoms. She's able to reduce her medication doses and the frequency.
So, sorry to interrupt the video. This is a very important moment. You saw how Cindy was walking like she was normal. So this is the expectation part. This walking that you see in the video is not better than her best levodopa state. So this is what we need to make sure when we do the levodopa challenge and all this process. DBS is not doing anything extraordinary or better than levodopa. It's just making sure that levodopa is working at its best for a longer time. Is that clear? I just didn't want to miss the opportunity to say that.
It also has a more consistent treatment of her symptoms because the electrical stimulation is constantly on. This evens out her overall therapy and improves her quality of life substantially.
I just asked Dr. Burek if I could go on a roller coaster, and she said yes, just make sure your battery's okay. And asked if I go water skiing, and she said yes. So I'm definitely gonna do those this summer. I have had great experience with this. It's great for me. It's wonderful. I can't say it enough.
All right, so results are not typical. That's what should be the disclaimer. So it's used to demonstrate one person's experience. It doesn't mean everyone's going to be like that. Everyone's Parkinson's is a little bit different. It will respond differently. The way that DBS works is the stimulation is constantly on currently versus taking medication, waiting for it to work, having an overshoot maybe a little bit, then you have it drop down in your body and there's a reduction in the medication working. So DBS is constantly on, even during the nighttime when you're asleep. It's been noticed that people can notice an increase in the length of the sleep that they have. Also, it's not uncommon that people have an improvement in the quality of sleep that is reported. That's not in everyone, but it's a trend that way, and it is something that has been reported consistently. So Dr. Lizarraga referenced this earlier when DBS therapy is considered. We have our hard and fast criteria that we go by. There's some variability with that. But anyone from a patient side of things, when do you consider it? When you feel like your medications just aren't allowing you to continue on with what you need to do. So do you feel disabled? Do you feel like it's impacting your day-to-day life? You're not able to get through it with your current regimen. Obviously, we'd like to enact this treatment as soon as we can so that we're not in the late stage of a condition where the horse may already be out of the barn. We're trying to, again, pick the ideal timing to do that. This is the timeline for the approvals of deep brain stimulation therapy. You'll see that we reference Medtronic frequently. This is the device company that helped develop deep brain stimulation with physicians. I'll give you a little timeline over the next couple slides about that, but there's currently 5 indications for deep brain stimulation that are FDA approved or at least have humanitarian device exemption approvals. First one was official in 1997. That was for essential tremor and Parkinson's tremor. The second one came shortly thereafter in 2002 for the other symptoms of Parkinson's disease, the bradykinesia, stiffness, Parkinson's tremor continued. And then in 2015, it was updated to have at least 4 years of duration. So we could do we had the FDA approval to widely do the surgery earlier for people with Parkinson's. It has a humanitarian device exemption since 2003 for primary dystonia. The dystonias are a very diverse set of conditions. There was never going to be enough study that you could get full FDA approval for it. It can be very effective for dystonia. So epilepsy was approved in 2018. We're doing more and more of that. And then OCD also got a humanitarian device exemption. That's not done by very many programs at all. It probably has a role for helping people with really bad OCD, but it's a much less commonly performed procedure. Worldwide, over 250,000 people have had deep brain stimulation performed. I spoke about the approval process. This is kind of the tracking of it scientifically. Why did we get to this point where we thought electricity pulses within the brain might help? And there's a lot of very smart people who made observations, who documented those, and then pushed to the next steps along the way. This is the approval and device process that has happened over the years. I've circled the main approvals for Parkinson's in green. So you see in 1987, which is quite a while ago now, right? That was the first implant. First approval for the tremor, the official approval by the FDA was in 1997. 2002, that was the expansion of the approvals for Parkinson's. 1999 is when the first DBS was done in Rochester, right, Carol? Carol was there. Carol's been there the whole time. So as Dan said, Carol's in the operating room with us and has been since the beginning. So she's the heartbeat of the deep brain stimulation program at Rochester. And then I circled 2020, which is when the first Percept device was approved for implantation in the US and European Union. That's the one that allows us to listen to the brainwaves while we're actually providing the stimulation as well. That's the one that will allow for adaptive DBS, and so hopefully there'll hopefully be a role for that to help regulate and improve symptom control with Parkinson's, and also using the DBS for that. There are investigational areas. Dr. Lizarraga kind of made reference to those. We won't be speaking about these, but there are studies ongoing that are looking to see if these conditions, dementia, depression, obesity, addiction, Huntington's, or Tourette's, have any significant role, if DBS has any significant role in helping with these long term. There have been a lot of studies that have been done, small series of people who have had these implanted. So far, there hasn't been enough to really get to the point where there can be any type of broad-based recommendation for those. You all know dyskinesias fairly well, I'm presuming, but I'm just gonna give you a quick video just to show what, the main symptom you're seeing with Michael J. Fox when he takes his medication is dyskinesia. So you're seeing all the extra movements. This gentleman walking down the hallway looks pretty good right there. And then there you go, advanced jig. And then bradykinesia, so
Don't stop.
got a lot of
Keep
tremor
going.
there, but the movement underlying is very
Okay.
slow.
With this finger, touch my finger.
Good Southern physician.
Now touch your nose. Touch my finger, touch your nose. Now the other hand.
Thank you.
And then tremor, you've seen that, you know what tremor looks like. All right, those are the principal symptoms that will have the possibility of responding to deep brain stimulation. This is the FDA clearance or indications that we have to make sure people meet for the standard DBS approval. Diagnosis of Parkinson's disease for 4 years. Dr. Lizarraga spoke about this. There's the other conditions that can look like Parkinson's early on and will not respond well to DBS if we do implantation in those. There's not a definitive diagnosis for Parkinson's. Even the marker that has been discovered is, we don't know how much of a role that will play yet in recommendations for deep brain stimulation. Eventually, with time, molecular biology genetics should allow us to define the category of Parkinson's that allows us to know with certainty that deep brain stimulation will work better. That's not here yet, but we can certainly hope it'll. Yeah, sounds like it. The aliens are here. We do want to see, for most people, independent. So if you have tremor, then that alone can be used as an indication for deep brain stimulation. But the other symptoms of Parkinson's, like the stiffness, the freezing, the slowness, we want to see how much those respond to levodopa, because the stimulation works like the medication works. That's why you do the medication challenge. You come in off medication and then on, and then we measure to see how much you've improved. We'd like to see at least a 30% improvement in your response to medications to say with confidence that you're probably going to respond to the surgery itself. The rest of this, these last 2 points, have to do with the motor fluctuations and how medications work for you, and really defining that they're not effectively. We aim for the whole way that the surgery works. The only way it works is if we place the electrode close or directly where your brain needs it to have the stimulation to give you the results that we desire, that you desire too. Everyone's structure, your brain structure is different. We get an MRI before surgery, but everyone has different electrical wiring, different chemistry. So even if we aim for one structure, that may not be the structure or that position of the electrode that you need to get the benefit. The structures are, just by the definition of surgery, deep brain stimulation, you can presume it's not on the surface of the brain, right? The electrode's going deep underneath the surface. So about 3 to 4 inches below the surface of the brain, just above the brain stem, is where the electrodes are going to be placed. We do have to open a little window to the skull that allows some air over the surface of the brain, and you guys know what it's like to open a can. Right? The relative position of the contents inside changes when you crack that seal. Maybe you don't think about that, but I do. So there's what's called brain shift. So even though you had an MRI laying in an MRI scanner and your brain's floating in spinal fluid inside your skull, the moment that seal is broken, even if it's a tiny little opening, even if we plug that opening right away, which we do, there's a little bit of a shift of the brain. It can be anywhere between 0.5 millimeter, it can be up to 2 or 3 millimeters. That's fine. That doesn't sound like that much because we're only talking about like that much. But our target is only about 4 to 5 millimeters in size. It's the size of a small, a very small
Grain of rice?
Well, it's kind of grain of rice. I usually say lima bean, but even like a pea, okay? And that floats down a little bit, you can miss your target entirely. So what we like to do is make sure that we hit it, because that's the only way that we're gonna be able to give you the benefit of the surgery. There are the 3 targets are used for the majority of deep brain stimulation right now. I reference them in cartoon form here. For essential tremor, we classically use the thalamus or the VIM nucleus in the brain, which is just the motor switching station of the brain. Subthalamic nucleus is the others that we use for Parkinson's, sometimes for dystonia, globus pallidus interna for Parkinson's and dystonia as well. We split nowadays are implanting about 50% of the time for Parkinson's and subthalamic nucleus, the other half in globus pallidus, the globus pallidus interna. And we decide that based upon several factors. Some of them have to do with your Parkinson type. Others have to do with the risk factors that Dr. Lizarraga spoke to earlier about cognition, mood. Those things can be teased out just by knowing you, by having you see our neuropsychologist before that everyone gets screened with anyways. And then we just have to place the electrode in the right place. And that has a minimum of 85% chance of being done. You can get up, obviously higher with other aspects of the surgery itself. Let's talk about the technical surgery. I'm not going to show you any gross pictures. You'll see some pictures in the operating room, but nothing that's going to be, what you would hopefully consider grotesque. The scalp, we do put some orange tape over the skin, so it kind of looks like, changed color, but it's kind of blurred out by the bright lights. So there is a team, to get to DBS, there's a team of people who are kind of at the center of that. I'm one aspect of it, but I'm only in and out briefly. I'm your surgeon, I'm there to do the surgery, to put it in, but your neurologist and the team that's surrounding the neurologist by far is the most important part of this. So the DBS team, we have movement disorder specialists. Dr. Lizarraga is key amongst those. We have a neuropalliative care specialist. We do work with a neuropsychologist to make sure that we've make sure we're doing the right thing for everyone. There's no major warning signs that we're gonna make you worse just by turning on the stimulation. There I am. We do work with psychiatry, and of course nursing is central to good patient care, to excellent patient care. The emphasis during this is what Dr. Lizarraga spoke about earlier, confirming diagnosis, optimizing the levodopa and the other medications surrounding your treatment to make sure that you really are optimized and surgery is the right thing for you. We do review all of the aspects of surgery. We talk about the benefits, potential risks, and alternatives that might be out there, including like the duopa pump, the insulin type pump 1, the other one, insulin pump type 1 that's coming. Review the potential cognitive issues, mood that could be impacted, and make sure there's a good social support system. Always are worried if someone comes to us when we do get people from far away to come in to have surgery with us, and we want to make sure that they really have a good support network. One of the companies has a way of doing the programming remotely. Problem is that there's a lot of that has to be done there's a lot of back and forth when you're doing the programming, that you need to see the effects now and then also later. And having it done in person is pretty important a lot of the time. It's a good alternative if there has to be some problem solving done to have it be able to do it remotely, but right now it's really best to do it in person. This is only a small portion of the team, but I want to be able to make sure you see their faces here. This is the neurology team. I didn't even include the surgery team at all. So there are 3 components of the actual implant itself. There's the lead, that's the part that goes into the brain. There's 4 contacts on that lead that allow us to shape the stimulation field to the area of the brain that's going to be best for you to get the effects that we are desiring. There's an extension that comes down the neck and then the battery pack on the chest that provides the programming abilities and the pulse of the energy. There are external components to the system. I'm highlighting on the right-hand side the patient charger unit, which is on, which is for the most recent iteration of the Medtronic rechargeable device right here. That's the patient charger unit, and then below it is the little Samsung phone that will connect and allows you to know the state of charge and allows you to turn it on and turn it off if you need to. On the left-hand side are our programmers, the physician programmers, and this kind of is the first time that it describes or shows how each individual contact can form this field. It's like a circular field or spherical field of electrical stimulation, and we can adjust it. We can adjust different factors of that stimulation field, the actual current. We can adjust the number of how long that current is on for in microseconds, and we can adjust how many times per second that those pulses are provided. So 90 times per second, 200 times per second, we can make those adjustments. And all of those variables can help contribute to different types of control of symptoms. So that we don't just set it and forget it, just one setting for everyone. Everyone gets a little bit of a different setting, and with time, it might need to be adapted. That's the tunable portion. Doesn't mean it allows us to try to reduce side effects from stimulation, because too much electricity can give you same side effects that you might get from too much medication. So we just like to be able to adjust the side effects to minimize them with the stimulation there. We do have the ability now to do the shaping of the field. The diagram at below is kind of how that is done. So the little blue outline right there is the traditional one contact that's been activated. The green is now being shaped by activation of one of the segments. Over here on the right side of the screen, you see these four contacts, these four circular contacts. These are the contacts on the end of the loop. The ones that we can shape with are these two in the center. They have three segments that go around the side, and we can activate each segment and pull the electricity one way or the other. So you can get these different shaped fields instead of this just concentric sphere right in the center. That again allows us to try to reduce the side effects long term because everyone, again, we may have the right place to the electricity, where the electrode is located, but we just have to pull the electricity away from another part of the structure that's impacting your side effects of your stimulation.
Question.
Yes.
It looks from the picture like the leads are on top of the brain. Are they not?
They're inside. I'll show you. Yeah.
They're inside.
They're about 4 inches below the surface of the brain, just above the brainstem.
Oh.
Yeah. Yes.
Can this device be underwater or wet?
It is.
No,
The charger underwater? Everything that you're seeing right now is all self-contained. The devices that are external shouldn't be underwater. Yeah, just like your cell phone and other charger devices should. Those are not gonna be, you're not using those when you're swimming. Those are just temporarily when you're charging the device or turning it on or off. Everything else is swimming in water. It's inside your body. All of this is inside, all self-contained, implanted. We still are doing this in a two-stage surgery. The first surgery, we implant the electrodes, and then the second surgery, again, about 2 weeks later, is when we put the extensions down the neck. They're all stretchy, and those extensions go down underneath the skin, behind the ear, down to the battery pack that's on the chest. So it's like where a battery pack for a pacemaker would sit. And that's about 2 weeks later, you get to go home after that surgery.
What happens if you need a pacemaker?
So there's options. So if you already have a pacemaker, we can put the bat stimulator on the other side. And the cardiologists can always put the pacemaker on the other side if you have a deep brain stimulation device that's implanted already. So that's the pulse generator, the implantable pulse generator, and that's underneath the clavicle there on the chest. And we usually have two, since we usually put an electrode in each half of the brain, you have 2 wires that come out and then run underneath the skin, go down, and both of those wires plug in. There's 2 ports, one at the top here and one at the bottom, one for each side. So we do this, we like to do this surgery awake with you if possible. We're able to do it asleep, but the success rate for putting the electrode in the right place starts to drop. You have about 20% chance of the stimulating leads not being in the right place if we just do it based upon anatomy. So we'd like to do it awake so we can hear your brain cells to confirm that we're in the right place. Because again, the only way it's really going to work for you is if the electrode's in the right place. This is where I say the brain target's about the size of a small pea or a lima bean. Yes?
How many leads actually go into the brain?
2, one on either side.
And then they join to one hole?
They, so there's two openings. They're passed down about 4 inches. They go down through the frontal surface of the brain in relatively silent areas. And then they're tunneled underneath the skin to the other side where we make another incision and then pass the stretchy extension lead down the neck to the battery pack. They don't join as one, they come to the same area and then are passed down with 2 separate wires.
So you do both sides at the same time?
Yes, we like to.
Why not do it awake?
Well, we want to do it awake.
I understand, but why would you not do it awake?
People can have anxiety about being awake during brain surgery. So remember, your brain is, you are your cells. So if we give you a drug that makes your anxiety go away, it turns those cells down. So we can't confirm we're in the place that we should be as well. There's a risk it will turn it off and we won't be able to see the right population of nerve cells that we need to make sure are in the location.
So you're awake, but it's local anesthetic?
Local anesthetic, yeah. So I'm going to show you in a few moments the surgery. And we hold you still by having you in a halo. The halo has little pins that push up against the skull bone itself. We put you to sleep while that halo is put in place, and we numb up those little pin sites. We used to do it with people awake, and most people said it wasn't that big of a deal. It was a little uncomfortable, like a little tight hat going on. But there's occasionally people who had a really bad experience. So now we just put people to sleep for 10 minutes with same medications they use for colonoscopies, if you've all had that. And then you're asleep for that, about 10 minutes, wake up, and the halo's in place. So we do put your brain to sleep for about 10 minutes. Then we let you wake up, and then the halo's in place, and then we numb up the skin itself. There's a drilling part to the surgery, you can imagine, where we have to drill a little hole. Takes about 30, about the size of a dime, yeah, the drill bit's about the size of a dime. So it rotates about 1,000 RPM, which is not like your dental drill. The dental drill is rotating about 40 to 60,000 RPM, so it's a real high speed drill. This it's a high torque, low rotation, so it vibrates a lot. That's probably the worst part. It's the sound, it's really loud, and it vibrates a lot. It's rare that people have any real substantial pain from that, but it can occur where people have some brief, sharp jab. But that's pretty uncommon.
Is the drill through your skull or through the brain? Through the skull?
Through the skull only. Doesn't go through the brain.
How do you patch that up, or don't you?
So on the video, I showed a little titanium plate.
Oh, yeah.
Yeah, that's the pothole cover.
Oh, okay.
It's a very thin titanium plate that's held in place with tiny little screws.
One other question, for the actual stimulation, does that affect the dopamine uptake, or no, it's more?
How does it, you're asking me how does it work?
Yeah.
We don't really know. We've observed that it does work and all the aspects around it, but we don't know the precise mechanism.
With the emergence of artificial intelligence, such an explosion almost, what kind of effect do you think it will have on the science of?
It's that all of medicine has yet to see anything AI in it, so we don't really know yet.
Dr. Wensel, you said, I believe, 85% you hit the target immediately, which means 15% you don't.
So there's a chance, we tell people there's an 85% chance the surgery will be successful for you.
Oh.
Once you get to a certain point of we've gone through the full evaluation prior to surgery, and that 85% chance, there's obviously a 15% that is not gonna meet those expectations. And that could be either from the electrode being in the wrong place, you having a type of Parkinson's that doesn't seem to respond to our surgery, or any number of other parts. But there's about 85% chance people have a good or an excellent response to deep brain stimulation.
So, but I believe you said you hit the target immediately. If you do not hit the target immediately, do you keep poking?
We can adjust the electrode trajectory, yes.
And
let me show you a little bit more. There's a little bit more that I have to show you. It probably will answer your questions.
Yeah, and then the other part of that is what damage does it do to your
A little
brain?
bit. Just a little bit, not enough, typically not enough to cause any major issues. The listening electrode we passed down first is the size of a human hair. It's smaller than the size of a human hair. So that's the damage. That passing down through the surface of the brain, down to the deep structures. So you can do this is referencing the awake surgery still. And then there are you may have heard of some of these other surgeries that are being offered, brain surgeries mostly. The first and the last one are essentially the same thing. Focused ultrasound is a lesion creating surgery. So it's one of the first type of surgeries we did for Parkinson's and for tremor was to go in and burn a hole in the brain. That's been done for many, many years, almost 80 years now. People have been doing that. There was the observation that people had a cessation of, the initial way this was discovered is that people had substantial tremor. They passed on, we did autopsies and we found holes in the brain in that area that seemed to control their tremor at a certain point when they had a stroke. So at that point, surgeons started to create holes in people's brains and control their tremor. Did that for Parkinson's. I believe that's what Michael J. Fox has had done. I think he had a thalamotomy done. But it's permanent, it's always there, it's a little stroke. It can work. We do use focused ultrasound now for some people for essential tremor who cannot have deep brain stimulation. It doesn't have a great role for Parkinson's at this point, principally because of what we've been talking about with the stimulation. It's something that we can adjust, and the adjustment is needed for Parkinson's. And then a sleep or guided MRI surgery can be done, but the success rate still drops from awake surgery. This is a demonstration, a side view of the regional anatomy for deep brain stimulation highlighted. And this on the left is a tracing of the cells, the population of cells that we'll listen to at different areas as we're passing this dotted line electrode down. And you can see that when we're not in the target, it sounds a certain way. When we're where we want to be, we hear cells. And then when we're down below, there's a change in character of those cells. This whole area is only a few millimeters in size. So again, you have to make sure you hit the right place. I'm going to show you in the operating room, listening to some of those cells. You're going to see different demonstrations of it over the years. We have one of our older microelectrode recording systems, and then we have our newer one that I'm showing up here in a few moments. But you're going to hear what sounds like static, and then you're going to hear some pulses in the static, and that's actually the cells firing. It's the motor cells of the brain firing. So here is one. On the left-hand side, this is actually the recording system, and this tracing are the cells being recorded with time. On the right-hand side, our patient sitting underneath the lights here. You'll see his hand shaking, and it will go along with the pulsing on the screen. Maybe it's going on with the pulsing of the recording. The person recording it. Can you appreciate the pulsing in the sound? Okay, so that's the tremor, not coming from the muscle itself. It's coming from his neurons in his brain firing with at the source. So, to start the surgery, this is our old frame. That's the halo, and this is the reference frame on top. This is when we used to place, this is an old photo now, back probably 2010. This was when we used to place these frames on without the IV anesthesia where you go to sleep. So he's only had the local anesthetic on, and he's still got a wry smile on his face there. This is our updated frame. It looks our halo, I guess we'll call it. And this is what we use now. This is how your head will fit into that halo. This is the ARC device that allows us to precisely listen to the areas of the brain that we're interested in, and then place the electrode at the last moment. This is what it looks like. I've anonymized his face as much as I could, but this is what it looks like when it's on. The local anesthetic is, you can see a little swelling to barely underneath that pin right there. That's the local anesthetic that has numbed up his skin. Even though he's asleep, we're actually holding him up. You can see my assistant's hand up above and holding his head up while he's asleep. Oh, you'll notice our OR looks really old. I keep it that way on purpose. This room in the basement of Strong is actually a Faraday cage. It's on its own ground. It was built, decades and decades ago. And every time they want to, and it's got a big, almost looks like a bomb door on it. Every time they want to renovate it, I say no. So it looks old, but it functions beautifully. So that's our operating room in the basement at Strong. It quiets down all the electrical interference, essentially. That's why it's important. After we put that frame on, we get a quick CT scan that lets me know where your head is inside that halo, and then I can import that into the computer. So there's the demonstration of the CT, and then we've done the planning on our computer planning system. This is your preoperative MRI that's been done, and then here's this green line that's coming down is the provisional plan for the surgery itself. So that's our planned trajectory for the electrode placement. This is what it will look like. Here's the outline of your head, and these little outlines are the computer system, our planning system allows us to kind of overlay colored cartoon diagrams of the anatomy now. So this is the trajectory of one electrode coming down to the planned nucleus of cells in the brain. That's then converted into an X, Y, and Z coordinate system. So that's what I'm circling here, X, Y, and Z. We get a number that we then put into our ARC system, and that will actually correspond to the exact location in the brain where I can pass the electrode once I've set all the coordinates correctly. We use this old ARC system. It's called a Lexel system. It's very precise. It's fixed to the halo itself. It cannot be dislodged unless there's extreme effort. We're not doing that. There's no extreme trauma that would allow for it to be dislodged. But there are other ways that we can do this. Frameless, we can do frameless devices. Those are a little bit more flimsy in terms of how they fix to the head. And there's also robot-assisted, which don't really make a lot of sense. The robot-assisted surgery doesn't make a ton of sense to use if you're only passing one or two electrodes. the additional setup time for that in the operating room is a couple hours. So this actually is more efficient, even though it still relies upon me putting the coordinates into the ARC system. So that's what the surgical tech is doing right now, is putting the ARC together, kind of like Lincoln Logs. You put them all together, putting the coordinate system in preliminarily, then we all double check it. Here it is. The electrode will then be coming down through here with our monitoring system above, and you're going to see again a little bit of that in the operating room. Now we're set up on the table, on the operating room table. You're sitting in a reclined position right here. Here's your head. There's that orange covering I told you about, but there's no blood there. This is the drive that actually drives the electrode down micron by micron to listen to each individual cell. This is Dr. Lizarraga, and this is our new microelectrode system that allows us to hear your brain cells well. Next is similar recording. Okay, so that also, again, you get to hear the shaking of the shaking cells come out. This is another way of describing that. These are all the same cell firing over and over again. There's a second cell that's a little smaller down here, and there's another couple that are close by that are firing over there. Listening basically to a small population of cells and confirming that we're in the right place. By doing that, we're able to, again, assess that we're in the right place. If we have to make an altered pathway, a second pass to listen to the brain, we will. I would say the majority of time we're accurate with our first pass. Carol is now going to show that you can hear the cells respond to the outside world as well. Carol's going to, I think, just gently brush along the patient's hand, and you're going to actually hear that from the cells of the brain. You're going to think you're hearing the actual sound of her hand against the skin, but it's not. It's actually the cells firing. So you'll see it up here. I don't know if it doesn't actually project too well, but you're seeing little population of cells firing exactly the same way. That's how you can tell you're in the right place. The last way to tell is to test things. It's really easy to test intraoperatively when you have a tremor, because if you're in the right place and you turn on the stimulation, the tremor gets a lot better. With Parkinson's, sometimes it's a little bit more subtle and you won't see a lot of those benefits until you've had the stimulation on for longer. But I'm going to show you a couple of patients who've had essential tremor surgery, and in the operating room we have this little target on the wall. It's a shooting target for those of you who can kind of recognize it. But we have a laser pointer being held, pointing at the wall. This is how bad the tremor is to start with. Okay. So now we do the surgery. And then over on the right-hand side, you're going to see once we turn the stimulation on. I thought that was going to be interesting. So now you can see the tremor is really well controlled. We turn it off again, and you'll see it comes back a little bit. And she says, turn it on, and you notice the tremor goes away again. This is a really nice demonstration of how you can get immediate results. You don't see that as much with Parkinson's. That's good. Okay, just to give you that warning. This is again demonstration of how.
Touch my finger, touch your chin, back to my finger. Good, and now hold, release.
And then the second demonstration for essential tremor patients, writing. That's before the stimulation's on. And then here's the stimulator being turned on in the operating room. Same patient.
Oh, that's a little different. Sign your name.
Okay. All right, Dr. Lizarraga spoke about those fluctuations. This is the diagrammatic display of what you experience with your Parkinson's when you take your medications, the on and the off symptoms, and then the dyskinesia overshoot. Again, you're going to see you should see, if you're a good responder, more control of that day. Hopefully those ups and downs now stay within this zone more closely in the on time period with less motor symptoms or dyskinesias. So we do implant, the majority of our devices we implant in Rochester are the Medtronic devices, the ones that were available since back in 1987. They are MRI compatible, both in 3 Tesla, which refers to the power of the machine, the magnetic strength of the machine, and 1.5 Tesla. It's currently the only one that allows for DBS therapy to continue to be on when you're actually having your MRI done. So it can hopefully help your MRI be done more comfortably at the time. And you'll see on the right-hand side of the screen, your patient controller, you can actually put your device into MRI mode yourself if you need to, if you're in a place that's not close by to us. There are these 3 major DBS companies. Medtronic has all indications for implantation. They're the ones that all of the companies have been, all of the therapies have been approved through originally. And these others came and they have developed some nice devices, but they still have all the indications that are approved through them. And then there's one that's used primarily for epilepsy, the NeuroPace RNS device. We put all of these in for one reason or another. This is the demonstration of all the upgrades for the device we put in right now. The Medtronic Energy Component Center, which develops the batteries, was formed in 1976 in Minneapolis. And then their first deep brain stimulation device was 1997. Next generation was the Soletra and Kinetra, 2002, 2003. After that was the Activa generation. That was the first one with the rechargeable. And we're in the current generation of device, which is the Percept PC and RC. I do want to speak to you a little bit about the rechargeable, because you think about having a battery implanted, and if it's not a rechargeable, you can imagine that battery is going to run out of energy at some point, and that means we have to replace it. There was a wonderful discovery made by a scientist in Buffalo who discovered that if you align the crystals in the battery a certain way, it actually gives you a little drop in battery energy right before the batteries die, like within about 2 months. They're able, with the components, the computer components within these batteries, they're able to pick up on that little drop, and it will give you a warning that tells you you're in the final phase of battery life. We used to have to, people would come in all the time with these original generations of battery that their device had just died, and we had to get them in and get them changed out right away. The second generation and third generation had that ability to pick up on the decaying battery. So we're able to change it before you lost all of your therapy and we're stuck waiting for several days to weeks before we could get it replaced. Now, the nice thing is that these rechargeables, since the Activa RC, this can go 15 years. The new one can go at least 15 years, and I'm going to show you why. I'm thrilled by this, frankly. You guys are all familiar with things that happen with your phone, your cell phone, right? You need to replace it after a few years because the battery just doesn't work anymore. That happens with all lithium-ion batteries to a certain point. So there's a patent that's owned by Medtronic that actually changes the battery chemistry completely, and I'm amazed by it, but it's also really bad for their business because people will stop getting battery replacements, which is bad for their business. But this is the traditional lithium-ion experience that we all have. So originally, 100% charge meant 24 hours of use, but then you get a 50% fade, and it means 100% battery only gives you like 12 hours of use. We all can identify with that drop in battery, useful battery, with our own cell phones and all the other battery-operated devices that we have. This new overdrive technology, the Percept RC, uses a battery chemistry called lithium titanate. The traditional lithium-ion batteries are lithium ferrous sulfate, or instead of using the graphite in these ones, they use lithium titanate instead of the graphite, which totally changes the way that the cell, they actually recharge and then discharge. So there's no change in the way that your battery should charge or discharge between day 1 and year 15. So instead of having to charge for longer, getting less use out of it, which is what we find with our cell phones, you should be able to go from a 10% charge to 90% charge in an hour, versus with the older version of the rechargeable, it can go approximately 4 hours from low to full for the old one as it gets older.
Is that wearing that charging thing on your?
That little charger that sits over, yeah. You don't have to have that connected to anything. It will connect up by itself. It's just like a Qi charger if you sit your phone on top of those little chargers.
Right.
It's exactly like that. You charge the charging device and then it hangs around your head with
You gotta wear that for an hour.
half hour to an hour. Depends on how you want to charge it. If you want to charge it when it goes down to 0, which you probably don't, because you don't want to get therapy. But if you go down to 10%, then you're probably going to have a 45-minute to an hour charge. But usually we're finding about 10 to 2 weeks for the amount of energy that's used. About every 10 days to 2 weeks is where people are going to need to charge their batteries. So if you're sitting down for a game, watching a game, knitting, you should be able to do it at the same time.
I do a lot of knitting.
Yeah. And then diagrammatically, this is what it looks like. So the energy capacity, they found that over 15 years, they still have 99% of the battery capacity left. I'm optimistic this could be a lifetime battery for most people, so it could go a lot over 20 years, which means I won't see you as often, but that's okay. That means less surgery for you. So what's our, here in Rochester, my specific experience, I was a resident during these times, so I saw the majority of the surgeries from 2000 to 2010. I picked up the program in 2010, and we've done over 500 DBS leads. That's not individual patients. It's close to 300 patients individually since 2010. And as things have ramped up, it's about 40 to 50 new implants a year. And this is the rough breakdown. About 30% of that is Parkinson's. It seems to be seasonal, or it comes in flurries. Like right now, we're in essential tremor flurry. Well, actually, we're both right. Epilepsy and then dystonia. Just based upon sheer number of implants, so you can gauge where we are relative to the rest of the neurosurgeons and systems in the world. My implant volume is 20th out of 350 US hospitals. So I'm not the busiest surgeon in the country, but I'm far from being the least busy deep brain stimulation surgeon in the country. All right, questions? Oh, more on the adaptive. One more thing on the adaptive. So anyone who's received the latest generation Percept PC, which is not the rechargeable, or has received the rechargeable, the current generation of rechargeable, anyone who's received that should be able to get the adaptive technology when that's released by Medtronic, just through a quick software update that we can do in the office, just through one of the antennas. So if you're concerned that you missed out on that, shouldn't be a problem. And you should even be able to go back to the old systems. So like the older generations, the wires themselves can still be used and attached to the new battery pack, so you don't have to go through that surgery again. So the actual implantable generator, the software within that, with the newer devices, the current generation, can be updated so you can take advantage of the new hopefully take advantage of the new technology. Yes?
With the new battery, will that ever eliminate the 2 battery packs for me?
That's a good question. Not likely.
Not likely. All right. That's fine.
If you got one battery originally, then so that would be easier to do. You'd have to have a much larger surgery to put it into one.
Okay, thank you.
So probably just having two rechargeables would be the advantage. And believe it or not, the old cost of just one battery is now about the cost of one rechargeable too. So that was also a bad business decision in my opinion, but that's fine. Not only do they not see them as often, but it's less expensive, which is great. It's great for cost of medicine and great for patients not having to come in for surgeries. Yes?
I'm a Parkinson's rookie as of February. I've been given a prescription for the levodopa, but in the literature that came with it, it says that if you have a history of skin cancer, which I have, you're not to take the levodopa. So my question is not so much what's this alternative, but what is the route to possible DBM if you've got to go through the levodopa first before you get to that?
We do address those questions when we're doing the evaluation. The first step would be to get in to see one of our movement disorder specialists through the university.
That's coming up in December.
Great. That would be the first step to see what options there are.
Is this usually covered by insurance?
It is. Yes.
How long is the surgery?
Varies. So there's a lot of sitting and waiting. Because we have to get the halo placed at the beginning of the surgery. We go up to the CT scanner. During that time, you're kind of in a haze because you got some IV medication. But it's about an hour and a half for that part before we actually get started with the surgery. The surgery time itself, about 2 to 2.5 hours. And then we give you some more sedation medication at the end while we're finishing up closing and stitching the incisions up. So it can be about, it's the morning. And so we go back from the pre-anesthesia area around 7:30, 7:45. Around 8 o'clock, we start putting the halo on. We'll come back down, and by about 9 to 9:30 is when we make incision. That's the beginning of the surgery. And we're usually starting up the closing process around 12. So 2.5 hours is the heart of the surgery. But from the point at which you leave your loved one's side in the pre-anesthesia area to when you see them later, it's pretty much most of the day. But you don't get to hang out with me that whole time. Yes?
How do you approach a patient with an older pacemaker that may not be MRI compatible?
Sometimes we don't have any options, because we really have to use the MRI as a guide for making sure we can get even in the right neighborhood for putting an electrode in. Sometimes there's options where a CT scan alone can be used for doing the surgery planning, but the MRI is really important. I can't tell you how important it is. It's really important for planning. So if there's a way to get part of the device changed out so that it's possibly compatible, talk with your cardiologist, see if that's an option. Yes?
What is the wait time for surgery?
It depends. There's a lot of snowbirds. A lot of people don't want to travel in the winter. So we end up having a real slow time about the beginning of the year. Right after about, January, February, we tend to have a slower time. And then picking up when you expect everyone to be coming back from warm and sunny and all the snows and ice is cleared up. Early spring to summer, we get slammed. There is a real finite resource, unfortunately, at the university right now, which is OR availability. There's a ton of surgeons who all want to be operating, who all have patients who need surgery, and it's a finite resource. We have actually a lot of that resource is committed to our program, the Deep Brain Stimulation program, and we will probably be getting more, but we can only do this 1 day a week. 3 out of 4 days, 3 out of 4 Mondays. We used to be able to do it every Monday, but then the pandemic hit, it took away everyone's time. And then we've only been able to scratch back a little bit because we don't have enough nurses, we don't have enough anesthesiologists. So we are getting there, but it's still a finite resource. So we're booking out, I would say 3 to 6 months is the range from the point which we decide surgery is going forward right now, where you'll probably be waiting that period of time. It's frustrating to me to say that, but we're picking off things as much as we can to try to make that better.
Do you do surgeries outside, for people that are outside of the Rochester area? I work in Buffalo.
Yes,
And so,
you have a great program in Buffalo, you have a great surgeon, 2 great surgeons who do this in Buffalo. But we do still see some people from Buffalo as well. And we see people down in
do you have
Pennsylvania.
those surgeons in at the end?
Yeah, Dr. Riley and what's the other one's name? John Riley's one of them. I can't remember the other one off the top of my head right now.
Does genetic testing, is it found to be helpful in the substantiation that it is Parkinson's disease for the surgery?
Right now, I'm not sure it was really that helpful, but in the future, probably will.
And also, how many times do you have to go in, or how frequently do you go in for, let's call it a tune-up, after you've had your base level?
A second surgery or more tuning of the system?
More tuning of the system.
So I'd say it probably takes 2 to 3 visits at a minimum to get optimized, because there's some adjustment to your medications that is made at the same time. You come in off your medication after surgery for your first tuning session, your first programming session, and then kind of as referred to by our former neurologist on the video, we sneak up to it. So you get probably a lower setting the first time, but we're gonna have to adjust your medications at the same time. So if you do what you were taking for medications before with the stimulator on, you're gonna have substantial side effects because they're cumulative. The stimulation and the medication's cumulative.
Is there any age limit for this therapy?
There's not an absolute age limit, but it's relative. And there's if you can't be off blood thinners forever, if you can't come off for surgery for like a month, then those are things that can be limiting. I always say if, you don't make it to 85, you're not gonna make it to 100. So you still may have another good 15 years to go at 85, right? So we need to make it as good as possible. So if your brain anatomy says we can get there safely, and medically you can go through 2 surgeries, then there's not an absolute contraindication to it.
I have a question. Has Medtronics have had any recalls in the past?
So as you know, recalls are not recalls. Like they always say Tesla has a recall. They just had to push a software update. There haven't been any black box warnings for the devices, nor have there been absolute recall that we have to take all the devices out and put them all back in. There'll be occasional technical notifications that when we see a patient, we have to be aware of X, Y, and Z, but no recalls per se.
How do you approach your doctor about asking about this, to do this?
It's different. I mean, some doctors know about it, others don't.
It's never been even approached to us, so that's why we come here from Buffalo.
Sure.
Although you say it's really great, for us, it's not really great. It's not as large as this thing here. We've gone with a few in Buffalo and they're not like this.
Sure.
So we have a great community.
Yeah, no, I think our program is probably one of the strongest in upstate New York.
Really great.
And outside of New York City, outside of Pittsburgh, I think those are the other places you probably would find programs that are as strong, that are probably doing the same volume, around that 20 out of 350 hospitals are probably up there. But so how do you approach it? You ask them if they know how to get into the program locally. And if you don't have that ability to see someone locally, then we're always happy to see you in our practice here at the University of Rochester.
One last question.
Any other questions? Sorry if I haven't. Which areas that have strong electrical signals might interfere with the operation?
Not much. Did you say interfere with the operation or the treatment? The treatment or the surgery?
The function.
I mean, you could be in an MRI machine, which has the strongest electrical field that there is, and that you could still be getting therapy there. So there's not really an issue.
Thank you, Michael.
Yes, you're welcome.
December 7th at Hinder of India is a social event. So you can go to our website to sign up for it. And I'd like to see you there. And one last time, thank you, Dr. Lizarraga.
Thank you.
See you soon. All right. Have a great weekend. Okay, bye.
Sounds like you probably haven't done in January.
Hopefully January. This is time for my birthday.
Gary, I have a question. I'm trying. You said you've been reading the literature. What does it say?
That was scary. So can't see them around. Like 3 miles.
No matter where you were, all you have to be was on a certain basis like warm. So does Okinawa. So does but yeah, I didn't. I'm not trying to be an alarmist. No, it's a good question. Like I said, I don't remember seeing that. Good pharmacy.
Well, no, you've had a couple of cancers.
So you sort of.
Were they, you have fluctuations. I mean, you don't know what so it's just yes.
Wait for a few minutes. I've been separate. never know. You see,
I would get it checked out.
I'm going. Yeah. I'm pretty good at finding stuff on ask the right questions, a verbal question, and it comes back. There is a supervising person. That when you go out and start I don't think about that. A joker. He said, well, it's indications, somebody's, two indications. Supervising person, so you stay with your